Hi, everyone.
Hello.
Hi, everyone. Welcome back. Welcome to our session on equity and access, building back better vaccine for the last mile and country conflicts. So this is really expanding on the sessions before from Professors Bundy and Hotez earlier. And I think it's going to be really exciting, having seen many of the comments and questions in the chat around some of the health disparities that we see today in COVID-19. So I'm very happy to introduce our panel today. Our first panelist is Cami Dar, co-founder and chief executive of Unita Networks. Cami, impact-focused leader and expert on systems, automation, data analytics, and talent management in the global development and impact sector. And he's currently the co-founder of Unita Networks, as a startup seeking to accelerate digital service adoption among the bottom billion, with a focus on equitable access and impact. Previously, Cami served as a co-founder and innovator-in-chief at the media platform for global development DevEx, where he spent almost 2 decades leading a team of analysts, researchers, engineers, etc., to drive world-class technologies that made DevEx the definitive hub for more than 1 million development professionals. Very happy to have him on the panel today. Secondly, let's welcome Val Gandhi from the Development Cafe. He is a senior evaluation, innovation, and tech for good specialist with over 19 years of interdisciplinary experience at both the field and policy level, implementing and leading qual and quant research, teacher training, and project management in monitoring, evaluation, strategic consulting, knowledge sharing, and capacity building with various UN, CGIAR, and donor agencies. Currently, he's the chief of party for the USAID, Indonesia's monitoring, evaluation, and learning support program for social impact. Welcome, Val. And finally, last but not least, Ruchika Singhal, the vice president of global health for Medtronic Lab. Medtronic Lab is a social business initiative to serve underserved communities. Prior to this current role, Ruchika was working for CR Bard as Vice President International. And prior to that, she worked at Medtronic again for 14 years in various roles on the business side across strategy, international market development, marketing, and new product development. But throughout her career, it's been a lot around scaling sustainable business models to address healthcare needs. And she's personally very passionate about healthcare and women's empowerment. So thank you and welcome to our interesting panel today. So over the past few months, it takes no mention of how COVID has really ravaged health systems and economies in countries across the world. While many would argue that a pandemic of respiratory disease was predictable, as mentioned by Pascal from Gavi before, the systemic failures of the response came as a bit of a surprise, I think, to many of us. From the shortage of hospital beds, medical equipment, to gross insufficiencies in national surveillance systems, supply chains, laboratory capacity, etc. It's really laid bare the healthcare limitations that global North and global South share. A stark set of differences, ever more apparent, is the radically uneven distribution of health, social, and economic risks associated with the pandemic, and the public health measures implemented in response, both within and between society. As concerns grow over a prolonged period of COVID-19 waves, further insights are needed into who bears the largest share of COVID-19 burden and why. We've talked a lot about that this morning. The pursuit of health equity is widely held to be the global health raison d'etre, and yet the deep equities laid bare by the current pandemic underscore that the field must do more and we must do better. In short, COVID-19 has really become a magnifier of health inequalities, and nowhere is that more evident than what we see in India over the last few days. So really, until we deprive COVID of new hosts, we all live under the constant threat of a mutation that endangers people in rich countries as much as it does in poorer countries. The head of UNICEF's COVAX coordinator for supply over the last few days says he fears many wealthy countries' vaccine donations may not come out until late in 2021, just when global supply is expected to ramp up, and that may cause a bottleneck. All doses may come in at once rather than at a slow but steady pace that allows countries with smaller healthcare networks to distribute them. But what we really need is doses now, when we're not able to access them via other means. The raging outbreak in India and the government's understandable response to accelerate vaccine efforts has inadvertently put pressure on what was already a constrained supply for COVAX. And that, he goes on to say that they're looking at the G7 governments and other wealthy governments to donate doses, not when everyone in these countries has been vaccinated, because that will be too late. So recent announcements by France, Norway, US, a great start, but much more is needed. Equitable dose sharing is now the best remedy for the disparities created by this nationalistic vaccine approach. Shared doses share lives abroad. They eventually save lives at home too, reducing the chances of new variants of concern washing up on the shores of countries that thought they brought the virus under control. So with all this, what should an equitable approach look like? It is a long-term agenda, but we're running out of time in some regards. So we proposed discussing potentially 5 frontiers of inquiry and action, focusing on the social determinants, the unequal effects of public health measures, the fragile systems that we've seen and talked about, the equities that exist within systems, and then finally the politics of global health attention and neglect. So with that, I'd like to open the discussion, and maybe I can draw to you, Cami, to talk about some of the social determinants you think are most apparent when we look at the COVID crisis here and now.
Great, thank you so much, and thanks for the introduction. Yeah, I think I just wanted to sort of highlight what I think is the elephant in the room, and that is that the main social determinant, so to speak, is poverty. I've ruminated, and this is not scientific, that the pandemic is in a sense a global Gini index of inequality and inequitable access. When you look at places, certainly India, Brazil, Philippines, where it's been really hard, but also within countries, you're seeing inequitable access to the resources, and not just the vaccine, which I think has taken a lot of attention, but also protective equipment, oxygen equipment, all kinds of resources. And so I wanted to draw a parallel with something that I think is both an example of the problem, but also a resource in the toolkit to help solve that, and that is the whole idea of digital adoption and access to digital. And when I say digital adoption, I specifically am referring here to not feature phones, the kinds of phones that have buttons on them and you can click, but smartphones that offer essentially a two-way service and two-way visibility. And let me just explain a bit the comparison here. First of all, they're both deeply systemic problems. And so when you look at all the different stakeholders who are involved, you have individuals and households, you have a private sector that's active, you have governance and governments who are trying to have impact on everything that's going on. And the really challenging thing is that all of these actors are on both sides of a really complex supply-demand curve when it comes to information, when it comes to resources, when it comes to money to make things happen. And so one of the things that we're seeing, and I just want to sort of walk through a bit each one of those stakeholders and then turn the floor over. So To start with, you have households, and in this pandemic environment, there's lack of access to information. In India specifically, one of the most surprising things is that the highly informed people have been very surprised by the pace at which the infection has taken over. After the first quarter being largely perceived as quiet, everything moved quickly, and there wasn't the infrastructure, a two-way infrastructure, to communicate to people and see where the problems were surging. Certainly, there's a lack of access to resources in households, and there's this idea of folks being in a poverty trap where you can't quite get enough resources to get resources, and that's a very paradoxical and systemic reality. And so one of our beliefs is, if you can blow through that part of the poverty trap and create digital adoption, you have a very different picture globally the next day. Very briefly on governments. Governments lack real-time access to data as to what's going on, and digital is a huge component of how governments could get better visibility. We often talk about gender segregated data. With some of the vaccine results recently, gender was a factor, and how visible is that on the ground in the environments where we're all working. And then lastly, you have the private sector. And the private sector is interesting because of the percentage of the economy that it represents, but also just the huge amounts of investment that have been made in digitalization and in e-health. So concretely, just in Africa, there have been more than $700 million of investment in 2020. There were $90 million put into e-health platforms with 180 active companies operating in that space. And here's what's fascinating about the private sector and digital services is, access was a problem before the pandemic. Access to education for children living in villages, access to healthcare for mothers living in remote areas was an issue before, and the pandemic just really shined a light on it. And so with the private sector, what you have is huge amounts of money being spent, really modern, smart, thoughtful, empathetic approaches, including human-centered design. And then we live on a planet where half the humans aren't actually participating in that conversation. There are services being designed. So there's a whole world of innovation, pricing innovation, product innovation that has yet to be done. And so the context here is, poverty is one of the key inputs into the situation that we have today, but it has so many outcomes that go back and impact the system. And so one of the goals that we have as a business, I don't want to get into it, but is imagining a world where we had comprehensive digital access, and we could address a lot of the issues, and this is the direction we're going in already, address a lot of the issues through that two-way conversation with citizens around the world.
Okay, so that would, so you're saying affordable digital adoption could be a key, as you say, to blow the way through the poverty trap. How about you, Val? What's some of your thoughts on that? And I know you've done a lot of research on this, and specifically around who are vulnerable populations, and how do you identify them?
Thanks, Kelly. So DevCafe is a think tank that works and engages with private sector and public sector. It's a self-funded think tank, so a lot of the activities they do are try to see how access and justice issues can come to the forefront. I mean, drawing on from what Kami said in terms of the social determinants that define access, most often when we measure whether a project is successful or not, be it in public health or other sectors, we commonly use criteria from OECD called the DAC criteria, which is a development assistance criteria used by large donors, and that primarily uses how to measure who is vulnerable and whether or not our project has achieved its intended impact. If we're talking about COVID, whether vaccines have been distributed or whether people have access to even testing and so on. But they have about 6 criteria: relevance, coherence, effectiveness, efficiency, impact, and sustainability. And we argue that these were very useful when they came in like 20 years ago, but given the social and complex environment that we live in, they are still not sufficient to see the dynamics in society, because they cater to mostly an accounting or accountability sort of evaluation of projects. I mean, whether or not something was distributed, whether there was toilets being built or vaccines distributed. But beyond that, changing the barriers or social determinants that contribute to those gaps in the first place is not measurable. So there is a concept called blue marble evaluation that is proposed by Michael Quinn Patton, and DevCafe adapts it to the next level. So instead of relevance, we look at transformation, fidelity. Instead of effectiveness, we look at the complex systems framing in which health or other sector programs operate. Instead of efficiency, we look at full cost accounting. But what's more important to us is, instead of the criteria of just impact, I mean, how many people have you reached, what was the impact, we try to look at diversity, equity, and inclusion as an outcome. And what do I mean by that is, we have to look at these things beyond equality and equity. I mean, equality generally assumes that everyone benefits from the same set of support, or equity is about everyone gets the support they need in terms of their capabilities, also known as affirmative action. But when you start looking at it from a justice perspective, then you go beyond equity and equality and try to look at the history of a problem. Why vaccines are not accessible, why some people do not have access to healthcare, and things like that. And those, when you start looking at justice, then you look at the histories of oppression, systematic and structural inequalities that exist in society, and then you try to address those gaps. Because when you talk about equality or equity, there is somebody who gives something away, or something gets more, or that's not sustainable in the long run. I'm not saying equality and equity are bad, they are great starting points. But ultimately, if you're talking about access and equity in healthcare, it has to have the language of oppression and understanding the history and context in which you exist, and use the context of justice, which is social justice, which looks at the complexities, determinants, and so on. Particularly when we now talk about using technologies like artificial intelligence and blockchains and so on and so forth to enhance healthcare or to improve access. And we always say do no harm, but again, harm is a very relative term, and whose harm it is and who is actually harmed. We talk about last mile, but there are people who exist beyond those last mile markers, and any intervention that we are trying to do, whether at a large scale or macro level or micro level, has to account for things beyond equity and equality, and that is what I think would ensure that social determinants that Kami was talking about really is enabled. Otherwise, it will be more of an accountability statement rather than a transformational change that needs to happen if healthcare has to reach everyone.
Okay, so do you have an example of this blue model approach? You know, a recent model in the COVID scenario?
So blue marble comes from the planet as the moon. When the astronauts went to moon and took a first photograph, they described Earth as blue marble. So blue marble evaluation assumes that we are all in this together, and that's why it's called blue marble evaluation. And evaluation has to be beyond equity and accessibility. One of the examples that I can give is, we did a project using blockchain for refugees. Refugees in Indonesia, for instance, they have no identity because Indonesia is not a signatory to the Refugee Convention. So they are, but nevertheless, there are a lot of refugees here. So we have a project called Project IM, which uses blockchain technology to enroll them in healthcare or sexual and reproductive healthcare practices. Again, because of the anonymity, it opens up their ability to access these services. Whether they ask questions about whether they were raped or abused by their learning centers they go to, or in the detention centers they are in, which they are not able to discuss before. So this platform enables. But even though the platform, ideally from our point of view as implementers, was successful, without doing the research from a transformative, if I was simply observing it as a traditional evaluator, I would say, yeah, we trained 200 refugees and 150 of them accessed it. But if I really want to make sure the system is accessed by itself and running, I need to understand what their problems are and why they are not accessing it, even though many of them came to the first session on the training itself. So that requires a little bit more in-depth and agile understanding and learning of the community we work with, rather than a waterfall linear approach where you introduce something and revisit them. But we use what we call as developmental evaluation, where we go through learning cycles with them in a more participatory approach to understand what makes them access this or not access this solution. I mean, in this case, it's a sexual health and reproductive rights platform. Nevertheless, the accessibility was low because the confidence level of refugees to access them was low, because they are scared, they lack confidence, and then they're afraid of even coming out in public and sharing these things, even though this is an anonymous platform. So without considering them, if we had just given and distributed it to a bunch of populations, then it would not be successful. So that's one small example. Again, Blue Marble is a more recent concept. The founder is Michael Quinn-Patton, but DevCafe adapts it, and he doesn't use the word justice. He calls it diversity inclusion, but we use the word justice to emphasize that equity and equality are only starting points. You need to be able to remove the barriers that causes the injustices in the first place, or lack of access in the first place.
Yeah, and I think you can provide. I think there's someone who would like the article reference on the OECD, that criteria that you talked about. I think you can definitely provide that, right, Val, afterwards. One question that came up: is Blue Marble evaluation part of an effort related to decolonizing global health? Do you have a perspective on that? Oh.
Sure. I mean, it's not specifically on decolonizing, but certainly it can be used. I mean, is this a question from the audience? Blue Marble evaluation is not part of that effort to. I mean, it's not specifically for that, but certainly it can be a good starting point, because if you want to understand what are the effects of colonial healthcare or health systems that are established in many countries, then certainly we can use this as a criteria, especially if you're looking at transformational fidelity and diversity and justice. Then certainly you can see why I was reviewing an AI policy for a UN agency, and see many of their existing systems are very so flawed, largely because of way it's designed. It's not that the artificial intelligence system is flawed, but people who code them are generally biased. And it's not even that the people who are coding them are bad people who are biased, but the system itself makes us in a way when we are part of that system. So if you don't, real transformation is not about Instagram posts or Facebook likes and sharing and being woke. It's really about inside out changing a system. So yeah, I mean, you can consider it as a tool to decolonize global health, and not everything that is colonized in global health is always bad, but it's really about removing what is unnecessary or just unjust.
Yeah. So Ruchika, maybe could you step in with some thoughts from your very programs that you have going?
Yeah, thanks, Callie. And, great to hear all of your comments. I guess from my perspective, I am not a global health person. So I've always been a medical device industry person. And coming into this space, I think our observations have really been around the healthcare system was never designed to take care of these types of challenges that we're dealing with. The healthcare systems were originally designed really for war efforts, and then you have acute complications, you go to the hospital and you deal with that. I think what COVID has perhaps illustrated in a very tragic way is just the need to redesign all of that to take care for the entire world's population versus for a few people who can afford it and who have access to that when they need it. And I think a comprehensive approach around how do you drive prevention and awareness and sort of maintenance outside of the tertiary care facilities is important. Like, we're never going to have enough doctors and, level 5 hospitals and trauma centers to take care of the world's population if we truly want to provide healthcare to them. And I think that's where the real opportunity is for innovation and digital tools to really democratize that and bring healthcare to people in their homes where they need it before it becomes an acute life-threatening event. And whether that's an infectious disease like COVID or diabetes, which, the WHO is renewing their focus on diabetes and the rising burden of that and cardiovascular disease across all segments of the world's population. I think there are just elements there that we have to start thinking about healthcare as, prevention and management versus acute interventions in a hospital. And that requires a mindset shift. I think the private sector, the civics, civil societies, governments, all need to rethink that, at least, from our perspective. And that's like, how do you build that in? Because all of our systems, processes, interventions are all built for when I have a problem, I'm going to do something about it, versus how do I prevent it from becoming a major catastrophe to begin with. So yeah, and I think that's where, like, to truly provide healthcare for the 7.3 billion people on the planet, in my mind, that's the only way to do it. If all we try to do is set up acute tertiary acute interventions in tertiary care, we'll just continue to run into justice issues, equity issues, access issues, and I think, yeah.
So what do you think? I mean, when you look at, I know there's a big focus in your work on, digital adoption.
Yeah.
And I heard something yesterday actually that the criteria for success of a program like one would be, of course, the systemic need. Secondly, that the local government is behind it, and thirdly, that it's integrated. So what do you see in because many of there's a lot of silo work going on, a lot of disease silo as well, a lot of discrete standalone offerings. What do you see, and how can we do a better job to help the equity issue?
Yeah, and thanks for that, Kelly. So we focus a lot right now on, chronic disease management, incorporating these ideas of prevention and wellness and avoiding complications, and we, digital technologies, digital platforms are a big part of it. Diagnostics are a big part of it. Community health worker networks are a big part of it. And our approach really is like, how do we build the ecosystem to bring all of these components of a solution together, integrated with whatever health system exists. So the goal is not to build a parallel health system, but really like strengthen that ecosystem so that you've got a digital backbone that enables a frontline community health worker to be able to go door to door and manage the health in the village where they're operating. And that eventually covers everything, like whether that's maternal childcare or TB or HIV or diabetes or, cardiovascular disease. And that, the dream would be that all of that is integrated, and you can train a health worker remotely, and all of those systems then feed in as like, the distributed sort of hub spoke model with multiple levels of hubs and spokes. We are starting to do that in the NCD space and looking to integrate with existing systems that are doing this around HIV, TB, and maternal child, because it's so it's not about like, oh, I have a digital health platform that I'm trying to get everybody to use, or I have a point of care diagnostic technology, let's just sell that and distribute that everywhere, or let's just train health workers. But to truly get the clinical outcomes that we desire, we need to put all of that together. And that's what we are doing in a bunch of countries right now, and really like focusing on the end metric being improvement, like clinically meaningful improvements in each patient's life. And that takes all of those components together, and reimagining those health systems. So yeah,
Okay.
it's hard to do. but it requires
Yeah,
from everyone and collaboration across the board.
very challenging. And Val, can you draw on some of your personal experiences in your work as well? And especially around the integration piece and how that can aid equitable access, I guess.
Sorry, I didn't realize I was muted. Again, as I was talking about, we try to see it from a project success or evaluation or sustainability perspective. And the emphasis on rather social justice oriented evaluation is really to seeking to increase the understanding of the interdependency of individuals, communities, or the governments, and even society using a more democratic process. As Ruchika rightly said, it's not really about what platform we have or what digital tools we have. They are not silver bullets. So that's why understanding the complex ecosystems in which they operate. And sometimes they are more expensive than having a straightforward blanket kind of an intervention. So from our example, because DevCafe is a self-funded agency, a lot of the interventions we do, we are able to adapt from a linear intervention to a more agile. But frankly, that's not very easy. It's easier said than done because you, as a country or as a country government, in some of my work, I work with several policymakers. So while they know this is the way to go for it, it may be challenging. So I can't finger point and say that this has been a successful project which integrated equity and access. But everybody has a starting point, and people have moved on from traditional ways to understand justice and access to healthcare beyond equity and equality. So that's all I can say from my examples. Although right now we're advocating through several agencies, through the Global Evaluation Innovative, the P2P Plus, and several other, both from the World Bank and also independent players, or working with agencies and ministries of public health to see how in the projects they can step by step go to that transformational approach. Because this is not something you can suddenly say, oh, I've had
an epiphany.
epiphany and I'm going to transform the way healthcare works in looking at access and social justice. That's not going to happen because a lot of them are still, it's a process to say. But of course, step by step, we can do in our zones of influence, like what Kami is trying to do through the Unity networks, or even what Ruchika just shared. These are all areas, are starting points to see that often in this challenges, what I find, especially when I speak to American colleagues, is the global understanding of what is justice is very different. Because for us, the empathy for another human being when I can afford something is not leftist thinking. It's just normal way of life. But in the US, when I speak about social justice or something, I sometimes have a culture shock because we are our brothers or sisters keeper. But when I sound like that, people might say I sound like President Obama, which I'm not, because it's just normal for an Asian like me or a South Asian to see that everybody benefits from a system. Sure, you make a little bit more because you're talented, and that's why I'm saying even when you talk about equality or equity, somebody has to give something so you can have a little bit more because you don't have. But when you really talk about changing areas, then it's really about empowering the people, and that starts with understanding the complex ecosystems in which healthcare operates or health systems operate. So as I said, I can't pinpoint this case study is successful, but we are trying to build awareness on why it's essential to include these factors in studies, in piloting studies. Yeah.
Thank you, Val. Okay, Kami, so let's go back to the UNITA and let's imagine a world for the future with your model. Can you explain how it would actually work to kind of blow away through the polity trap, as you termed it?
Yeah, well, first of all, I love the conversation. I think just to build on a couple of the themes briefly and then tie it to what we're doing, Novartis Foundation did some really excellent research in Ghana around telemedicine and showed that phone consultations can reduce visits to the clinic by roughly 50%, referrals to hospitals by roughly 30%. Obviously, transport changes substantially. People spend huge amounts of time getting to places where they get medical attention, often don't get served when they get there and have to make the trip again. So there's a whole world of empowerment, as Ruchika rightly called it, and democratization of access. The other thing that I wanted to just pick up on was, this idea, community health workers as a central part, and obviously this expertise and the asymmetry of information between the patient and the health worker or the doctor is really important. We're at an extreme in the global north where we're self-diagnosing everything with online resources, which is its own problem. But the thing that I want to emphasize is that health outcomes don't live alone. There's correlates in financial outcomes, correlates, and I think this idea of blue marble, it's both the earth and it's round and it's connected. And health, education, employment outcomes are all intrinsically tied, and there's something around the way the digital economy is evolving that is connecting those ideas. Health outcomes actually, and health data and education data impacting your how easily you can borrow money from a bank, for example. Again, there are complex social issues around that, but you're seeing some of these issues converge. So I think the best thing, and we almost don't have to imagine a world of high percentage of digital access. If you look at countries that have very, very quickly digitalized, like China, you see a tremendous amount of economic activity, a tremendous amount of access to resources, and fundamental behavior change that goes in a whole range of directions. We look at school access. We're doing our first pilots in Ghana, and we're very early stage. And I appreciate that Ruchika said that she's not a health expert. Certainly neither am I. But a lot of the realities on the ground that just prevent basic access to health is something that a lot of us are familiar with in the work that we've done around the world. And so this idea of, if we could snap our fingers and tomorrow we had an 85 to 90% smartphone penetration across the global south, there are entire new economies. We're talking about fully 50% of the planet not being a part of the fastest segment, the fastest growing segment of the economy, and having their voices included in a participatory way in what that world will look like. One final point on AI is, as Val was saying, the
just
idea
one point. We need to wrap up.
Oh, sure. Is that AI is something that is accelerating the pace of change of how data is used and how health outcomes will be supported. And so every single day that half the planet is not part of this economy, they're losing ground faster and faster and faster because there is not this digital footprint the way that all of us today have and are building upon. So the issues that they're facing are going to be harder to serve in the years to come.
Thank you, Cami. So I know we need to wrap up. Thanks to everyone. We hope the discussion gave a glimpse of the many ways in which COVID-19 pandemic has intersected with and exacerbates social and health inequalities. If anything, the current pandemic has really been, I think, a powerful reminder that health is much more than just a medical matter, as it's embedded within a complex set of social, economic, political determinants. The current crisis underscores why the pursuit of health equity should remain top of priority in global health, but it also lays bare the gap between the equity ambitions of the global health field and healthcare realities. So I hope it all gives us some food for thought moving forward in terms of how we need to focus and the action plans around that for the long term. But thank you all to the panel, and over to the next session on resilience. Thank you, everyone. Thanks a lot.
Thank you all. Thanks, Carrie.